Hello and welcome everyone. Today we will be discussing a topic which is the science behind left ventricular unloading. So, cardiac cycle and the myocardial forces. The heart experiences a time-varying forces on the myocardium during its cardiac cycle. These forces, termed as load, influence heart's function. The concept of the work in the heart. It is defined as the energy transferred when the heart pumps blood originating from the cellular oxygen consumption. LV unloading. So it is defined as an active reduction in this myocardial work and oxygen consumption through specific strategies. It is aimed at promoting myocardial recovery and reducing the VA ECMO complications. So we are looking at a scenario where I have a myocardial dysfunction for which I have attached VA ECMO, and we will see what complications arise when I attach VA ECMO and how it will hamper my myocardial recovery, and by doing what strategies I will unload this left ventricle. So there is also a concept of left ventricular venting. So we must know the difference. Unloading is focusing on reducing the work of the myocardium and the oxygen consumption, while venting targets lowering the left filling pressures and the pulmonary congestion with minimal effect directly on the left ventricular work per se. So this is the basic diagram which we will be using throughout our presentation. This is the loop, that is the pressure volume loop of the heart. This is the diastolic point. At this begins the blood flow from the left ventricle onto the left atrium to the left ventricle. It occurs at very low pressures. This is the pressure, this is the volume. So you can see the volume is increasing inside the ventricle, but the pressures are very low as of now. It is from the atrium to the ventricle. This point, that is this point B, is the end diastolic volume. This is the end diastolic volume. This is the end diastolic pressure. This was the end systolic volume. So we had a filling of the ventricle at low pressures. It is followed by what is called as the isovolumetric contraction. So what you can see here from B to C, the heart is contracting. It has initiated the contraction, but the pressures are not high enough to open the aortic valve. So this is the isovolume. The volume doesn't change, but the pressure shows a sharp increase. This is the isovolumetric contraction. From point C to point B, what we get is called the ejection phase, where the aortic valve opens and the blood is ejected into the arterial system until the end systolic pressure is reached. This is the end systolic pressure. And the stroke volume here is defined as the end diastolic volume minus the end systolic volume. So this minus this will give us what is called as the stroke volume. Then we have what is called as the isovolumetric relaxation. It begins after the aortic valve is closed, leading to the relaxation of the ventricle, which results in a pressure drop. So there is no volume change but a sharp pressure drop, which is shown here as the isovolumetric relaxation. So this is the loop along which the heart operates. Then we have two curves, the diastolic pressure volume curve and the systolic pressure volume relationship. So we'll come to the details of this later on. The things that you can see here is the diastolic one is curved while the systolic one is straight. And from the end diastolic volume point here to the end systolic volume point here, the graph that is drawn, the line gives us the elastance. We will come to all this later on again. So coming first to the preload. Preload is defined as the indexed by the end diastolic volume or the pressure. This is the preload on the heart. The relationship between filling pressures and the volume varies with diastolic dysfunction. If I have a diastolic dysfunction, these values are going to be affected. That is the volume and pressure. So the PV loop shift, this is the PV loop that we have. This loop will shift if the increase in the preload happens. If there is an increase in the preload, that means this B point is shifting over here. So there is a rightward shift, the volume is more. So I have a rightward shift of the PV loop. So increasing the preload will result in a rightward shift of my PV loop. Decreasing the preload will shift the PV loop leftwards. So similarly, if it comes down over here, my PV loop will be shifted down, left. So experimentally, preload reduction, that is via inferior vena cava occlusion, shifts the PV loop leftwards, this side, indicating low end diastolic volumes. Next is the afterload. Afterload is defined as the effective arterial elastance or the arterial resistance to the dilatation. It incorporates all the extracardiac factors that impede the ventricular ejection. So EA calculation is done by this formula over here, which is derived from the Wien-Kessel's model. The slope of the EA line I have shown in that place is approximated using this formula. Here you have the end systolic pressure, which is divided by the stroke volume, which could be equal to the heart rate into the total peripheral resistance. If the total peripheral resistance is more, my afterload will be more. So as you can visualize in that graph, my EA will be increased. So my EA will be increased if my peripheral resistance is more. So impact of increased afterload, it leads to the rise of the EA along the slope. So this is my slope, my point, that is the point at which the end systolic pressure and volume is reached, will be higher up over here. So this is where I will reach if my afterload increases. It shifts the PV loop rightwards. As you can see clearly, it will shift the PV loop rightwards. And obviously my stroke volume will reduce. So my work will finish sooner. So my stroke volume will be reduced. Increased afterload due to the total peripheral resistance or heart rate raises the end systolic pressure. This will rise. As I go up, my pressures will be also higher. At the expense of ejection, my stroke volume will be reduced, negatively impacting the mechanical efficacy of the heart. Next is the diastolic pressure volume relationship, the below curve that we have seen. End systolic pressure volume relationship. So it's a linear relationship. So as we had seen, the systolic relationship is linear, along which that graph was following. It approximately is a linear relation. The physiological relevance is that the VO is influenced by the extrapolation method and inotropic state, and its physiologic significance is as of now unclear. The ES max, that is the elastance max, is the load independent measurement of the ventricular contractility. It increases with positive inotropism, that is with drugs or sympathetic agents. It decreases with negative inotropic agents or with infarction or myocardial ischemia. So time varying elastance model. The entire cardiac cycle as a variation of elastance can be modeled. The elastance increases during the systole and maximizes at the end systole. Next we have the end diastolic relation, the bottom curve. It is a non-linear relationship. It represents the lower border of the PV loop. It reflects the passive mechanical property of the left ventricular chamber. The influencing factor here are the size, orientation, and the mass of the myocyte and the extracellular matrix. It is affected by ischemia, edema, remodeling, fibrosis, and hypertrophy. The slope, that is the delta P and delta V, it indexes the left ventricular chamber stiffness, which is load dependent. The compliance is the inverse of stiffness, that is delta V by delta P, and the curvilinear nature, it explains the loss of compliance at high volumes, indicating a progressive left ventricular dilatation. As my volumes increase, my ventricle will become more stiff. So the compliance is described by this formula, while S is the diastolic myocardial stiffness, Vm is the maximum allowed diastolic ventricular volume, and V0 is the diastolic volume at zero pressure. So if we use this formula, we can get what is called as the compliance. Then we have the work done. There are three types of things over here. The first is the stroke work and the potential energy and the pressure volume area. So first is the myocardial work. The PV loop area gives us the myocardial work, which represents the external myocardial work, that is work performed by the left ventricle to eject the blood. Then we have a potential energy given over here. It is the additional area under the end systolic pressure volume relationship area, which represents the potential energy stored in the ventricular walls. When the ventricular wall has finished its ejection, still then also it is maintaining some kind of tonicity. That tonicity is what is called as the stored potential energy. And the potential energy is related to the viscoelastic property of the myocardium. Next, we have the oxygen consumption. It is linearly related to the pressure volume area and not just the stroke work. It is influenced by the heart rate. Higher heart rates increase expenditure and oxygen consumption per minute. So my energy expenditure is both the stroke work, that is the external work, that is the area in the loop, along with the potential energy, which is the graph below the end systolic pressure volume relationship. So cardiac mechanical efficiency is the conversion of energy. Part of the energy produced by the heart is converted to the external output. That is what we see as the cardiac output. Remaining energy is lost as internal energy. So the efficiency ratio is the stroke work divided by the oxygen consumption. Under normal circumstances, the ratio is around 10 to 25%. Factors which increase this are, that is increase the oxygen consumption, are the overload, that is cardiac myopathy or acute heart failure. Increased heart rate is a compensatory mechanism for this. Calculation for the oxygen consumption is derived from coronary sinus blood flow and arterial coronary sinus oxygen content difference. So this is the oxygen content difference and the sinus blood flow, which gives us the oxygen consumption. So CaO2 here is the arterial oxygen equal to the coronary oxygen content. Impact of the coronary flow is significantly drops the coronary flow negatively, impacting the oxygen consumption and the delivery balance. The next is the ventriculo-arterial coupling. So this is defined as the dynamic interaction between the ventricular ejection and the arterial pressure changes. Now it represents the global cardiovascular performance and its efficacy. It relates the ventricular contractile function, left or right, to the arterial load during each cardiac cycle. It is given by this formula, that is EA by EES. This EES is the load independent myocardial contractility index, or the stiffness of the heart during the systole. The EA, it incorporates the arterial load, includes the peripheral vascular resistance and the total arterial compliance impedance and the systolic diastolic time. So basically this top one is the artery, the compliance, and the ES is the stiffness of the heart. So this is the mathematical formula for it. So the optimal coupling, it approximates one, where there is optimal ratio between the stroke work to the total work, including the wasted energy. The clinical relevance is, here is that ventricular arterial decoupling occurs in conditions like acute heart failure, cardiogenic shock, and septic shock. Right ventricular pulmonary artery coupling applies the same concept but to the right ventricle. So ventricular interdependence is something which is also there. So diastolic interaction main determinants include the interventricular septum displacement, ventricular compliance geometry alteration, and the pericardium. And there is also systolic interdependence, where the left ventricular contraction contributes to the right ventricle's ejection. So coming back to a curve again, the PV loop changes during cardiogenic shock. In this, you will see that the end systolic pressure volume relationship lowers. This goes down. So it reflects a reduction in the inotropism of the left ventricle. The LV shifts downwards and rightwards. It goes down because this line goes like this. So my graph shifts right and down. So it indicates a worsening left ventricular function. The ESP, that end systolic pressure, decreases quite naturally as the graph goes down due to the impaired left ventricular contractility. The end diastolic pressure and end diastolic volume increase because the heart is unable to eject out the blood properly, these pressures are going to increase. The compensatory mechanism to maintain the stroke volume is an increase in the end diastole. Because this is coming down, I have to shift this up to maintain my stroke volume. This has come down, this will go up to maintain my stroke volume. So it fails as cardiogenic shock progresses. Now, as long as that stroke volume is maintained, I am doing okay. But there will be a point where this will not be maintained. That is the point where, when the stroke volume is not maintained, we go into what is called as cardiogenic shock, because my stroke volume has reduced, and this will ultimately result in the blood pressure decrease and the low height of the end systolic pressure, which will ultimately impact my tissue perfusion. So unloading and reduction of the myocardial oxygen demand. The unloading is defined as reduction of the myocardial work by minimizing oxygen consumption, reducing hemodynamic forces, causing the ventricular remodeling. Unloading reduces the area of the PVA, which is correlated with the myocardial oxygen consumption. I will reduce this part. So mechanical support findings. Studies of the PB loop under different mechanical support strategies show that various impacts on the myocardial work and oxygen consumption. So there are some limits and downside of using this PV loop analysis in our clinical practice, because it is I'm directly putting a catheter in the left ventricle. It has high cost and invasiveness, and I do get an incomplete analysis because PV loop does not account for the myocardial wall thickness, the cross fiber shortening, and other key cardiac pathological elements. So unloading effects related to the mechanical circulatory support. So we will discuss the circulatory supports and how they impact it. The first one is the IABP. It mainly functions by deflating during the systole and inflating during the diastole. So what are its effects? Its effect is that it reduces the central aortic pressure, the aortic impedance, and the systemic vascular resistance. And it increases the aortic diastolic pressure, thereby lowers the central aortic and diastolic pressure, and increases the coronary blood flow, which is the main benefit that it gives. It improves the stroke volume as well as the ejection fraction, and it decreases the myocardial stroke work and the pressure volume area by reducing the end systolic pressure. It enhances ventricular arterial coupling. So next is Impella. Impella is a device where the left ventricular assist device, which is introduced percutaneously to unload the left ventricle. It is considered a promising technique to unload the left ventricle. The changes in the PV loop due to Impella is that it shifts the curve leftwards. How does it do it? It lowers the left ventricular volumes and the pressures by actively ejecting the blood. So the pressures are going to go down, and it produces a unique triangular shape. The curve will become triangular due to the loss of the isovolumetric contraction and relaxation phases. Because the machine is going to do the work of the contraction, you may not find this type of a picture where these will not be there. A continuous pumping of the blood from the left ventricle to the aorta alters the loop shape, and it reduces this area. It leads to reduced mechanical myocardial oxygen consumption, and it has been shown experimentally by Braunwald to correlate with the tension time index, that is the area under the left ventricular pressure curves. So the benefits of Impella are: it reduces the left ventricular volume and pressure, lowers the oxygen consumption, but it has some challenges. It requires skilled and trained staff. Potential complications can include nasal bleeding, stroke, ventricular perforation, access site infection and bleeding, lower limb ischemia. Other than that, we have one more device that is called tandem heart. It's a mechanical support device which again unloads the left ventricle. It draws blood from the left atrium and returns it to the main artery. Example like subclavian or axillary or femoral. The hemodynamic changes is that it reduces the end diastolic pressure, increases the left ventricular stroke volume, increases in end systolic volume to generate sufficient left ventricle pressure for aortic ejection. And its impact on the PV loop is that it decreases the area of the PV loop and reduces the oxygen consumption, similar to the Impella. Now the concept is, once we put a patient on ECMO, we need to left ventricle unloading. Why is that? Because the ECMO alters the balance between arterial and venous circulation by draining venous blood and pumping it into the arterial system. What it does is it increases the left ventricular afterload, increases the left ventricular preload, and the left atrial and pulmonary pressures. Because the blood is being drained from the venous blood and is pumped into the arterial system, my afterload increases, and my also the preload and the pulmonary pressures are also increasing. It reduces the left ventricular preloaded output, but it thereby affecting the pulmonary circulation. And there is a patient device interaction. There is a complex interaction between the native and the artificial blood pumps, like the venous and the pulmonary as well as the arterial circulation. Retrograde ECMO flow increases left ventricular afterload. Now PV loop changes. The PV loop, because of a ECMO, because my pressures are increasing and it becomes more narrow. There is reduced native left ventricular stroke volume because the native heart is not able to pump much, and taller. So it becomes very slim and tall because of the increased afterload. It shifts rightwards and upwards along with the end diastolic pressure volume relationship, and there is a possible increase in the oxygen consumption. So the complication is the potential for left ventricular overload is there, leading to aortic valve non-opening, intracavity blood stasis, and intraventricular thrombosis. Because the native heart is unable to pump against the increased afterload, there is a high chance my left ventricle will become stasis, and there can be a chance of thrombosis. Left ventricular overload, this extra work that the left ventricle is being forced to do, will not help me to treat the primary disorder, which was something in the heart, because my heart myocardium was already damaged. That is the reason why I had to put a VA ECMO. So putting the patient, so my myocardial recovery is also hampered. So mitigating strategy is to avoid vasopressors, use vasodilators, diuretics, possible end expiratory PEEP ventilation, limiting the ECMO flow, combined mechanical support. This is the thing that we are discussing. Using mechanical support along with ECMO to unload the heart needs to be done. The use of ECMO with IABP or Impella can shift this pressure volume downwards and leftwards, reducing the oxygen consumption. So these are the unloading techniques. You can do this surgically or percutaneously. The unloading strategy first is Impella with VA ECMO. The combination effectiveness is that it mitigates and avoids the overload. It increases the cardiac output, increases oxygen supply, and decreases oxygen demand. And left ventricular loop changes. It continuous pumping from the left ventricle to the aorta, removes the isovolumetric periods, and the PV loop changes from the trapezoid to a triangular shape, shifting leftwards as the left ventricle is unloaded. The clinical outcome is there was a study done which showed lower 30-day mortality in this particular technique with compared to VA ECMO alone. The increased complication rates were though observed because we are doing two devices at the same time. Mortality reduction seen with early unloading but not with late unloading. So if you were planning to do a VA ECMO, it is better to do with the cover of Impella because it will unload your myocardium early and improve the outcomes. So other percutaneous unloading strategies are intra-aortic balloon pump can be used, arterial septotomy, pulmonary artery drainage cannulation. Comparative effectiveness is the ECMO plus Impella showed most effective PVA reduction compared to strategies like atrial septotomy, pulmonary artery drainage in porcine models. Clinical data shows that till date we have no clinical data which supports one strategy over the other because there have been no direct comparisons. Lack of facilities comparing different unloading and strategies are indicated for specific indication to be used like that only. Now, biological response, the overview is ventricular unloading influences various biological pathways including cell hypertrophy and atrophy, calcium handling, protein gene expression, neurohormones, inflammation, extracellular matrix fibrosis, endothelium, vasculature, angiogenesis, cardiac metabolism, bioenergetics. The impact of left ventricular pressure and volume overload, it depends on whether the setting is acute or chronic, also influenced by underlying myocardial etiology. So there is pathological remodeling of the left ventricle. A study of the pressure overload induced left ventricular hypertrophy, fibrosis, and changes in cellular autophagy were seen. Aortic debanding showed reversibility of this, that is pressure unloading showed reversibility of these alterations. Post ischemic hearts, dysregulation of the energy metabolism and apoptosis is seen. Several chemokines are released, and the study by Esposito et al. Showed that left ventricular unloading before reperfusion reduced the downregulation of the genes related to the energy metabolism and increased respiratory chain genes. So there is improved outcome because of this. And left ventricle unloading in acute ischemic setting. The timing and infarct size is important. Left ventricle unloading reduces the infarct size in myocardial infarction, and it is a crucial endpoint in clinical trials. And the infarct size increase is associated with higher mortality in almost all these setups. So unloading reduces the oxygen demand and improves my infarct size. There is also renal benefit, improved outcome in terms of AKI is also seen, and the clinical implication is combining ECMO with Impella to reduce the atrial response to distension and increase total cardiac output is important. The theoretical benefit in reducing the arterial stretch and normalizing the ANP and RAS signaling helps us in improved outcome in terms of the renal also. So coming to the conclusion, cardiogenic shock effects increase the end diastolic pressure and volume, leading to downward and rightward PV loop shifting. So what happens is we need effective left ventricular unloading where we want to reduce the myocardial oxygen consumption. Impella, IABP or tandem heart are effective in unloading the left ventricle, while the VA ECMO may overload the left ventricle. The benefits of unloading is that it reduces the infarct size and reduces the myocardial inflammation, prevents fibrosis and remodeling. Potential application for organ unloading in kidney and other organs as well. However, we do need further research before we can implement these strategies at our bedsides. Thank you for your patience.